Neurology, pathology, effects of strokes. All right, so for this podcast, we're going to be talking about the specific areas in which a stroke can occur and what the deficits will be after that stroke has occurred in that specific vessel. Okay, very, very important, very high yield, and it's going to be easy. All right, so first off, we'll talk about the anterior circulation. So we have the ACA, the anterior cerebral artery, okay, the ACA. This is straightforward because we talked about where does the ACA supply blood to. If you go and take a look back at the homunculus, if I were to cut my brain in half, right, looking at it right down the center, that's where the ACA supplies blood to, okay? That medial area split down the middle, all right? And we know that the homunculus provides both sensory and motor function to the lower limbs in that area. So if we have an ACA stroke, you're going to have motor and sensory loss in the lower limbs. Okay, boom, very easy, right? Because you lose that aspect of the brain. Now, a question that they like to ask, and I remember it, I'm so pissed that I missed it. I always hated when they asked this question, but it was something that I got like once. For the anterior cerebral artery, the strokes at that location of the ACA are usually distal to the anterior communicating artery, okay? So the ACOM, if you ever have a stroke at the ACA, you're gonna be distal to the ACOM, okay? So just keep that in the back of your mind. It's just one question that I got that I missed. Next is the middle cerebral artery, or the MCA. Well, we know where the middle cerebral artery supplies blood to, right? Think back to the homunculus. It's going to be the lateral aspects of our brain. And the lateral aspects are going to have both motor and sensory function to our upper limbs in our face, right? So we're going to have contralateral paralysis and sensory loss to the lower face and the upper limbs. Very easy, okay? Now, if you have, like, for example, an MCA stroke that occurs in the dominant lobe or dominant hemisphere, usually the left side, right? In most people, it's usually the left hemisphere that's dominant. You can see aphasia, okay? Because, once again, the dominant area is where we have Broca's and Wernicke's, okay? Which are covered by the MCA, all right? And we know that Broca's is located in the frontal lobe, all right? And Wernicke's located in the temporal lobe. So remember that image of the brain. Don't get confused, but all of that's supplied by the MCA. So if we have a problem with the MCA on our dominant hemisphere, usually the left side, you can present with aphasia, okay? If it's on the non-dominant side, you can present with what? We discussed it already previously. You can present with hemi-neglect, okay? Right? Good. So hemi-neglect is usually going to be seen in the MCA strokes of the non-dominant hemisphere. It's very straightforward, okay? All right, next is going to be the lenticular striate artery. Okay, the lenticular striate artery, what you need to know, the large takeaways of it are this. One, lenticular striate strokes are usually secondary to hypertension, okay? They will usually lead to contralateral hemiparesis, okay? And lastly, the basal ganglia are usually affected, okay? So we already discussed it when I was talking about the basal ganglia, but patients that have lenticular striate artery strokes, they usually have it secondary to hypertension, and it can lead to contralateral hemiparesis, okay? But if it affects the basal ganglia specifically, what do we say? I'll let you think about it. When it affects the basal ganglia, there's one specific area that it could potentially hit, and that would be the subthalamic nuclei. So if it hits the subthalamic nucleus, then it can cause hemibolism, right? We already discussed that, okay? So key takeaways for lenticular striate strokes. 1, hypertension. 2, leads to contralateral hemiparesis. And 3, the basal ganglia is usually affected. And if it hits the subthalamic nuclei within the basal ganglia, it can lead to hemibolism, okay? Now, the last thing they like to ask about lenticular striate arteries is essentially what you'll see on histology. You're going to see lipohyalinosis with small vessel occlusions, okay? Because it's a type of hyaline atherosclerosis that is secondary to hypertension. If you were to take a look back at cardiology section, we talk about hyaline arteriosclerosis is usually caused by hypertension. So this is the same. It's just in the brain, right? So because lenticular striate strokes are caused by hypertension, you're going to see a hyaline arteriosclerosis. So a lipohyalinosis with small vessel occlusion is what they might potentially say. All right, so good. We're done with the anterior circulation, the ACA, the MCA, and the lenticular striate arteries. Next, let's move on to the posterior circulation. First and foremost, we have the PCA, right? The PCA supplies blood to the occipital lobe, right? So what happens is that you can get contralateral hemianopia, okay? Anopsia. So you lose vision in the contralateral eye, okay? As well as hemisensory loss, potential contralateral hemisensory loss, okay? But if you ever lose vision, remember, it's going to be the PCA, okay? But you can have macular sparing because macular sparing which just means that you can have like central vision sparing. So you might lose all of the other vision, but you still will have your central vision because some areas of the occipital lobe can be supplied by the MCA or the ACA, depending on where the stroke occurred. Okay, so you can have dual supply from different arteries. But if it's solely the PCA, you can have contralateral hemianopia, okay? Contralateral loss. All right, next is going to be the basilar artery. So remember we discussed the basilar artery, okay? The basilar artery is a branch of the vertebral artery, and it's above the vertebral artery. So that means that it's not going to be supplying the lowest portion of the midbrain, or lowest portion of the brainstem. It's going to be at the middle portion of the brainstem, which is the pons, right? So the basilar artery supplies the medial pons, okay? And whenever we have the basilar artery that's knocked out, you'll have the medial pons knocked out. And so now let's think back to our rule of fours, okay? What cranial nerves are going to be medial pons? So let's walk through it. We have the midbrain, which is 3 and 4. Both of those are medial, but we're not at the midbrain, we're at the pons. Okay, so let's keep going. 5, 6, 7, 8 are the cranial nerves at the pons, but the only one that's going to be medial is going to be both 6, or only 6, right? So you're going to be losing the 6, okay? But you can also see a potential locked-in syndrome caused by basilar artery issues, okay? And this can lead to an inability to move or speak. And whenever it says the patient can't move their eyes horizontally, then you know that it's going to be locked-in syndrome, okay? And this is caused by ischemic injury to bilateral ventral pons, okay? Okay, so this is a patient that genuinely cannot do anything. They can't move their eyes horizontally, okay? So they're literally just locked in. But the key there is they cannot move their eyes horizontally, all right? And that's going to be a basilar artery effect of stroke if it hits bilateral ventral pons. So that'd be a massive stroke, okay? But remember, the basilar artery supplies the medial pons, okay? So that's why you have loss of horizontal but not vertical eye movements, because what gives you horizontal eye movements? Cranial nerve 6, back to the rule of fours, okay? All right, next is the AICA, the anterior inferior cerebellar artery. This is going to be a branch of the basilar artery, okay? So that means it's going to be at the pons level, right? But since it branches, it's not going to be medial, it's going to be lateral, okay? So this is going to be the lateral pons. Well, what's located in the lateral portion of the pons? Well, let's go back to our rule of fours. We have cranial nerves 3 and 4 at the midbrain. Well, we're not at the midbrain, so let's move on to the pons. Pons, we have cranial nerves 5, 6, 7, 8. Remember, the only medial cranial nerves are the ones that go into 12. So everything else besides 6 is going to be lateral. So 5, 7, and 8 are going to be lateral. So that's precisely what you see. Whenever we have lateral pontine syndrome, which is essentially a stroke of the anterior inferior cerebellar artery because it provides blood flow to the lateral pons, you're going to see facial nerve hit, right? Because cranial nerve 7 is going to be affected. So cranial nerve 7 is affected, so you're going to get essentially somewhat like a Bell's palsy. You have the facial nerve hit, and so you're going to get a paralysis of the face, okay? That's pretty much the highest yield thing that you need to know about that. Next is going to be the posterior inferior cerebellar artery. This is going to be the PICA, okay? So the PICA is a branch off of the vertebral artery, right? And the vertebral artery is the lowest that we talked about, right? So that means it's going to be accompanied by the lowest portion of the brainstem, which is the medulla, okay? But the vertebral artery supplies the medial medulla, and so the PICA, since it's a branch of the vertebral artery, it's going to supply the lateral medulla, okay? And the lateral medulla, once again, let's go back to our cranial nerves, the rule of fours. 3 and 4 are located in the midbrain. 5, 6, 7, and 8 are located at the pons. Okay, we're still not there. 9, 10, 11, and 12 are located at finally the medulla. Okay, but we're talking about the lateral medulla. So 9, 10, and 11 are going to be the lateral parts, the lateral cranial nerves. And that's what's going to be affected via PICA. Okay, specifically what they want you to know for 9, 10, 11 is 10, the vagus nerve. Okay, so what happens is that once you hit PICA, you're going to get the presentation of hoarseness. Okay, so patients get hoarse because cranial nerve 10, the vagus nerve, is hit. Okay, so they have a hoarse voice. They also have ipsilateral Horner's syndrome. Okay, and we'll talk about Horner's syndrome later on, but you have to remember that PICA is going to have ipsilateral Horner's syndrome. All right. Now, you also have decreased pain and temperature sensation from contralateral body and ipsilateral face. Okay, that's just one thing that you have to know as well. All right, but other than that, dysphagia and hoarseness are your key things for the lateral medullary syndrome, right, caused by a PICA stroke. It's also known as Wallenberg syndrome. All right. And then lastly is the anterior spinal artery. There's really not too much that comes from this. The medial medullary syndrome is what happens, but there's not too much that you need to know about it. It's not too high yield, okay?